Thank you for being with us today. I'm Sandra Arevalo, and I'm the Director of Community Health and Wellness at Montefiore Nyack Hospital, with you once again in these community chats that we do every Thursday from 12 to 1 for all the community. Today, we're going to be talking about migraines. I know there is, this is a very interesting topic. A lot of people have been actually emailing me. Please talk about migraines, and we got a lot of registrations for today. So thank you so much. And I love having suggestions because it saves me the headache of thinking what topics do we need to be showing. So that's great when you guys email me and give me feedback and give me ideas for new topics. So for our attendees, thank you very much for being here. And just a reminder that this program is really for you. So if you would like to make any questions, any comments, use the Q&A, use the chat box. Just tell us all your thoughts, all your questions. That today we have Dr. Andrew Arian here, neurologist from Montefiore Nyack, and he's going to tell us a little bit more about what the work that he does. But he's amazing. And I'm sure that he's going to answer all of your questions about migraines today. I myself, I'm a migraine patient, unfortunately. And this morning, I have to say, I had to take one of my pills for migraines, believe it or not, because I woke up with a migraine. So good thing that we're talking about this. And I don't know, maybe I'm sure somebody of any or all of our attendees might also suffer migraines here and there. So, Dr. Arian, thank you so much for being here today. I really appreciate it because I know you're a very busy person.
No problem.
So why don't you tell us a little bit about you? What is it that you do? What's a neurologist, for example? And then we can start talking about our topic.
Okay, so I'm Dr. Arian. I'm neurology. So my specialty is the brain and the nerves, and where they extend. So that's like the spinal cord, muscles. We deal with a lot of headaches, stroke, seizures, autoimmune illnesses, pain, neck, back, big ones, or neuropathy. Those are the most commons. On top of that is dementia, mental changes, and neurological issues caused by other diseases like Lyme disease or MS, etc. So that's where neurologists are. I am headache certified, so migraines actually is one of my specialties. So that's what we do. We're in Tow Cross Field at Nyack. I'm also in the hospital at Nyack Hospital. So that's where you can find me. And everybody in the group also treats headaches. So that's where.
And we're very lucky to have you here at Nyack Hospital because I love not only the work that you do, but your personality is amazing. So that's
thank you.
It's a great professional to have and to work with. So that's great. So let's start talking about migraines. How do you differentiate between a migraine and a headache?
So migraine and headache. So all the headaches. So so headache is general, and then under headache we'll have different types. So there's migraines, and we'll break that into different fields. There's tension, there are cluster, there are hemicrania. So there's different types of headaches based on how long, the location, and the type of the headache. So for migraines, the thing we look for is you have 5 or more attacks in a month. They can last from 4 hours to 3 days, 4 to 72 hours. And you have 2 of the following. They're one-sided. They feel throbbing. They can be moderate to severe, and they're worse with physical activity. You also need one of the following, which is nausea and vomiting. Nausea or vomiting, actually. It can be either one. And you're sensitive to light or sound. To us, that is pretty clinically a migraine.
Mm-hmm.
From there, we decide which way we're going to go, depending on symptoms, issues you have. So actually, let me go back. So migraines have, we'll say, 3 phases. The prodrome, which is before you get a headache, the brain is having changes. Some people get an aura, which is a warning. They might get zigzag lines, or they'll get flashing lights, which means the headache is coming. Those patients have the ability to take the medicine faster because they know it's coming. Then you have the actual headache, which is the symptoms I described. Close the lights. I can't go to work today. That'll last. And then after, could be up to a day where you have the prodrome, which is you might feel sluggish, you might feel tired, but you have no headache anymore.
Mhm.
So the reason this happens is we call it cortical depression, which is it's like throwing a rock into water. Oops, sorry.
We can hear you fine.
Because I'm covering the hospital too. So what will happen is you will have this wave that kind of spreads from the center of the location of the headache out. And that's why you'll have symptoms starting, you'll have the full headache, and then it goes back to normal. So that's how the migraine starts and finishes.
And
Oh,
how,
did I lose you?
no, we're here. And how severe, can you hear me? Dr. Arian? Yeah, I think we lost you or you froze. For sure you froze. And we lost him. He'll be back in a second, I'm sure. So in the meantime, I know that you guys want to make questions. So please start writing your questions in the chat, the Q&A. Let us know what you think. Or, maybe in your comments, you have a question about your own cases or somebody that you know. So please use the Q&A in the chat. And we're just waiting for Dr. Arian to come back.
Sorry.
That's
We're in
fine. So
we are having.
I was going to ask you, how severe can migraines be? Something that we need to worry about, like run to the emergency room, something that can be treated at home?
Okay. So there's two ways we treat headaches. One is abortive. We give you medication for now to break the headache. One is prophylactic, which you take every day or you take it regularly to prevent it from coming. So those are the two styles we give. If the headache gets too severe, you do come to the emergency room because there's special medication we can give you to break the headache. It might take, but it can be done. They're usually IV medications such as steroids or anti-nausea medicines like Reglan or pain meds like Toradol. There's a cocktail we usually use that we can break the headache in the ER if it gets to that point. At home, usually your neurologist will give you a steroid dose pack, and it's like 7 pills today, 6 tomorrow, 5, 4, 3, 2, 1, and that usually has very good success to break a headache. When should you be worried? So let me go back. If you ever have a headache that's the worst headache of your life, go to the ER, because headaches can be nothing or they can be something. If you're diagnosed with migraines, we worry about the headaches if you have change in severity, new symptoms, new onset, or if it's associated with new issues. Like before, your headache used to be the light bothers you, but now the headache makes you dizzy. Before, the headache used to only last 2 hours, now it lasts 2 days. Any changes from your regular migraine is when we get worried. You need to either see the neurologist or go to the ER. Mm-hmm. Other than that, it usually follows a certain pattern, and most patients know. I mean, 3 million patients are diagnosed a year. 92% of the headaches are migraines, or at least one of them is a migraine. So the patient will know. Like, I know around my menstrual cycle, I know certain triggers, certain foods like chocolate, wine, cheese, alcohol, MSGs, certain chemicals in foods, fried foods. I didn't sleep enough. I slept too much. I was on an airplane ride. I'm highly stressed. I'm staring at the screen too long. They know things that will bring it on, so they know this is how it's going to play out. Things that are out of the outliers, that's when we worry.
Mm-hmm. And what could be some of the consequences? Why do we need to worry? So
thing that worries me
We're losing you again, Dr. Arian.
This is
We're losing you again.
worst headache of my life, or it feels like not a migraine. That could be something I try to do on the side. Connect to you on the side. Better?
Yes.
No. Okay. I'm gonna try to connect you on both sides because I don't have you. We have no internet right now in the office, so I'm using my phone. About worst headache or thunder. We call it thunderclap. It's like a large boom goes in your head. These are not migraines. This is something completely different.
Mm-hmm.
Can migraines put you at risk for other issues? Very small percentage of patients who have auras, which is when you see the zigzag lines, or if you have remember I said there's different types of migraines. So there's migraines, we'll say common, which is the light bothers me, the sound bothers me, I hear throbbing. That's common. Classic is you get a warning, zigzag lines. There's also abdominal migraines, which is you get nausea and vomiting. That's your symptoms. There is vestibular. You only get dizzy with the headaches. There are, we call them complicated migraines, where you'll have, it looks like a stroke, but it's not. You might have trouble speaking. You might have loss of vision. You might be numb or weak on one side. Those are called hemiplegic migraines. This is why you should be checked out, because it's not a stroke. It's actually part of the migraine. And to know that difference, especially for the patient, because you'd be scared if you saw it. Like you'd think, oh my God, like I'm having a stroke. So these symptoms should be evaluated just to make sure, better safe than sorry, that it's not something very bad.
We actually got a question. I have a niece just diagnosed with hemiplegic migraine that has been diagnosed as strokes for over 20 years without knowing what was wrong. What do you think?
Makes sense. The thing is, the science, no, not science, the knowledge is most people think migraines are just a headache. Or people who don't have migraines think it's a bad headache. Unfortunately, get over it. But they don't understand when you see the patient or you see the symptoms. It's not, there's a headache component, but there's other things. And hemiplegic migraines are often diagnosed as a TIA or a stroke, sometimes seizure, until a full workup is done. You know, certain things are evaluated. I'm not sure who this, I'm not giving official medical advice. I don't know who the niece saw or what spectrum it was, but it does not surprise me that it was diagnosed as a stroke.
Is there a way to prevent migraines?
So going back, so when my patients come to me, big things we have are, what are your triggers? So usually let's walk backwards. Patient comes to me first time, I have headaches. I'll do a full neuro eval, full history. I'll look to see, is there a family history? Because 2/3 of patients have a family history. My mom, my sister, my aunt. Usually it's on the female side. It can be on the male side too, but usually it's female. Even male patients, my mom, my sister, my aunt. So there's a familial pattern that might follow. Then you'll hear, we'll talk about the onset. How often is it? How long does it last? Where does it go? Where in the head? How severe? Any associated symptoms? Anything you notice makes it better or worse? Anything you've tried at home? Tylenol, Excedrin, Advil. Have you ever been on migraine meds before? Have you seen a neurologist before? And it'll give us like an idea of where you are. I'll have them have a headache diary. So they will have like a calendar. I had a headache on this day. I did not have a headache on this day. It was this much. It was this little. So you have an idea. From there, then we come up with a plan. Some patients want a medication every day. Some patients only want it when they get a headache, and that will be determined by the patient's frequency. We divide them into, chronic migraines or acute migraines. Are your headaches 4 days a month? Are they less than 15 or are they over 15? Those are the three numbers I look at. If you're only getting them, say, 4 times a month, they last for 4 hours. I'm not going to put you on medication every day. I will give you the abortive medication, which is, do you take it when you get it? This should break it. If you're getting headaches 8 days and up, or you're telling me, look, those 4 headaches that I get are hell. I can't go to work. I can't play with the kids. Then maybe we need to do something every day. So abortive meds, you might have heard of them, like sumatriptan, Imitrix, rizatriptan, the triptan, we'll call it the triptan families, because it's dependent on how you get the medicine. You can get it by nose, you can get an injection in your thigh, or you can take it by mouth. And each route is for a specific reason. If you have nausea, you can't take it by mouth. So it'll be inhalation or injection. If you have nose issues, breathing issues, you can't take it by nose. So the type of triptan is based on your symptoms and which way I'm going to give it to you. There are also other meds. There's Excedrin, there's Furoset, there's now the CGRPs, which is this new class of medications where they will only target the molecule of the headache. Everything has a risk, a benefit, and a side effect. So we need to figure out your history, your symptoms, what's the best thing without causing more issues with side effects. That's to break them. Daily medications, there are a bunch of medications. I mean, I would say at least 15 meds that we can pick from, where you take it every day, you take it every night, you might take it twice a day. The new set now is Botox is an option. It's not for plastics, but ironically, when I do it, part of the pattern we fall actually does do the face. So yay. It's not meant for that, but it can be. Yeah, no patients really complain
So
about
now
it. But
I do have a question about that, and I think a lot of people here might be thinking about the same thing. Botox is usually like a cosmetic thing, right? So it's not paid by insurance. Would it be paid if it's for migraines?
yes.
That's great to hear. Look,
but there's a process. There's
today.
Insurance will pay, but there's a process. We have to try certain medications and they have to fail. But Botox is an option, but it's not your typical, 2 shots. It's 31 shots. It's
that's it.
1, 2, 3, 4, 5, 6, 7. These are usually the plastic or the dermatology ones. But then you have 8, 9, 10, 11. Then on this side, the same 4. Then in the back of the head, 3 at the top, 2 at the bottom, and then 3 on your shoulder, each side. So it's 31 shots. It's not just 1 or 2 and that's it. And it's every 3 months.
It's every 3 months that you have to have the 30-something shots.
Well, you should. I mean, if you want to keep your headaches away.
Yeah.
That's one type of medication. The other one now is the CGRPs. There are injections. You probably heard of Aimovig, Emgality, Ajovy. Those meds are an injection once a month. In some cases, once every 3 months, depending on how it's prescribed. That's it. 1 injection in the thigh. You're good for a month.
Okay.
We find these new meds have good success. They are fresh. To me, fresh is within 5 years because we don't. But they have a low side effect profile, so the patients are happy. And it's not like I forgot to take my medicine or I ran out. It's once a month you get a shot. That's it.
Is that a shot that you can take at home too, or you have to go to the provider to get the shot?
Take home. At least no, you can take it home. For me, we either instruct you, we show you how to do it. You can come to us if you're uncomfortable, but most patients do it at home because they're
like self-injectables, like the insulin pen.
Oh my God, what's it called? Yeah,
We're losing you again.
10 seconds. They make it easy. They better. Good.
Yes. So you were saying the type of injection that you can do yourself?
They're auto type, so they're designed to be easy for the patient. You just hold it down, it pushes the needle by itself, it pulls it back up, it injects the medicine. You just have to hold it down for like 5 to 10 seconds.
That sounds great. Okay.
Yeah.
Now, what about coffee, Dr. Arian? Because I know, for example, Excedrin, it has an amount of coffee in it, and I know some people drink coffee for migraines. So
there is a caffeine effect on migraines.
okay. And we're losing you again. We're all gonna have a migraine after this. We cannot hear you. I think this must be a Wi-Fi issue, Dr. Arian. And
Did I get you back?
yes.
Yeah. I just got told we have internet in the office again, so let's see if this works.
Okay.
But I am telling you that, yes, they make it easier for us to use the medications because they want it to be used. They know it works. So they're happy about it.
Okay, but we were talking about coffee, and you probably answered the question, but we couldn't hear you. So you said coffee has an effect.
So caffeine has an effect. So you'll notice that some patients, one of the things that I will do is I will try to use caffeine with it. Like I'll tell a patient to, you can take it with soda. You can take the medication with coffee. The only thing I don't like about it is that sometimes what will happen is you'll start to get used to the caffeine. So if I didn't have my coffee today, I have a really bad migraine. So they're withdrawal headaches. So that's the only, yes, it works. Yes, it can help you. I just get worried that sometimes there will be a withdrawal. Like I didn't have my cup. And then there's also a building effect, right? So before it was 1 cup of coffee. Now I need 2 cups of coffee. Now I'm up to 3 cups of coffee. So it's like, I don't want you to go down that path. Some patients already use coffee for whatever they need their coffee, and we can work with that.
Yeah. We have a question, Dr. Arian. My wife gets intermittent migraines, sometimes twice or three times a month. When she gets the migraine, she loses vision and weakness on the side, primarily on the right side. Should she be on a continuous medication? And is there any chronic damage from frequent spells?
So that's a loaded question, actually.
So it sounds like it's one of those yeah, the hemiplegic migraine, because she's losing vision, weakness on the side. So what type of medication would you recommend for this type of migraine? And you're on mute now, by the way.
Can you hear me?
Yes.
Yes. So I'm connected to the computer now.
Okay.
So we'll do it this way. So let's break it down. Let's start over. Tell me by sentence by sentence.
Okay, so she gets the migraines 2 to 3 times per month. She loses vision and she gets weak on the side, on the right side primarily. So what type of medication do you think will be good for her? Something to take daily or one of those injections that you were talking about?
First, she needs to be evaluated. I'm assuming she already sees a neurologist. She should have had imaging just to make sure it's nothing else. And usually we'll do a carotid to check blood flow, to make sure everything is proper. Then from there, we can decide which medication, because I don't know her full history. You know what I mean? I don't know what other medical issues she has. I don't know,
Recording in progress.
like, does she have diabetes? Does she have high blood pressure? Does she have high cholesterol? There's a bunch of other things to consider. It's not just an easy question. But one thing to consider is calcium channel blockers. Sometimes, I don't know if she will qualify in this. She might qualify for the CGRPs. Aimovig might be helpful. I can't give a generic answer for it.
Yeah, because you were saying before that the medication that you choose also depends on the side effects, on the medical history and all of that. So that's why you mentioned there were like 15 different types of medications that you can use. But I like when you said, the patient should be evaluated. And the second part to the question is there any chronic damage from frequent spells?
So assuming it's a migraine,
Yes.
Is there any chronic damage? So anything is possible. Ideal is probable. So low, moderate, high. I think that it would be a low risk. However, my other question is to this patient, if you're having these symptoms, my question is, what are the other pre-existing medical history you have, because that might add to issues. Headache by itself, the classic oral type, which I said, and we call it basilar migraines, which is where they might have both sides are numb, both sides are weak. That can cause a small, very small, but higher risk than the normal population for stroke.
Got it. What about, you said that sometimes exercise triggers migraines as well. Wouldn't exercise be recommended, especially, for your back, your shoulders, when you get a lot of pain from those areas?
So actually, one of the diagnosis requirements is exercise would make it worse. In some patients, exercise-induced headache, which is not a migraine, but it's a different type of headache. Like I said, there were headaches, migraines, cluster, tension. There's a type known as exercise-induced headache. That's separate from this, but there's a treatment for that.
Okay, so for these medications that you can take daily, is that for patients who have frequent migraines, or it could be also for people who have sporadic episodes?
Both.
Okay.
Both. I will go through the list of meds, the side effects, and it depends on the patient. I have patients who have headaches twice a week, and they'll say, I don't want to take a medicine every day. I just want it for certain days. I have patients who have headaches once a week, but they last a day or two. I want a medication every day. We have to look at the side effects. Some medications cause kidney stones. So in a kidney patient, I won't start it. Some patients, it can cause lower blood pressure. If your blood pressure is already low, I'm not going to pick that one. So each person is unique, and then we uniquely design a treatment for you. You can do a one-size-fits-all. I can say, this medication works for migraines, try it, we'll see. But you might have side effects, you might not take it ever again, based on how we started it. It depends on you.
Now, Dr. Arian, there are medications over the counter for migraines, like Excedrin, right? Would you recommend that if you think you're having a migraine, you just go and get some Excedrin and do it with that? Or do you feel that everybody should be evaluated?
I think everybody should be evaluated ultimately. Excessive migraine is helpful because it is close to one of the medications we use to break headaches. It has caffeine, it has, I think, aspirin and the acetaminophen, but it's missing a component used in a prescription type. But if a patient tells me Excedrin helps and they give me a story that sounds like migraine, I'm more confident towards that.
Mhm. Okay, so Excedrin wouldn't help everybody, I think you mean.
Yeah, it doesn't help everybody.
Okay.
And also take it as directed. I have patients who will take much more than they should, and then we'll have other issues that we have to deal with.
Dr. Arian, can you explain a little bit how the migraines happen in your brain? Is it inflammation? Is it what's happening in here, and why the side effects of the migraine? Like why the nausea, why the vomiting, or the weakness, all of that.
Okay, so
Am I
Give me a
putting you in
second.
trouble?
no, it's not as one sentence answer. I'm thinking of how to word it. We will say this. Certain ways that the blood flows to the brain and certain ways that the blood vessels dilate and constrict will affect the headache. Because there's a lot of process. There's biochemicals, there's receptors, and that's why we have different medications, because they work on different receptors in the blood vessels or the brain. So something changes the blood vessel dilation, which distorts areas, and depending on the area, determines the symptoms. Like we said, the hemiplegic, it could be in the motor area. So the headache started there, that's distorted, this side gets weak. The headache is by the area of nausea, vomiting. So you get the symptoms. Some people have ocular migraines. They only have vision symptoms. They lose vision, or they get blurry vision because of the location. So I think that's a good answer.
Yeah, no, that makes a lot of sense. Yeah, obviously, that's why it's so different. And by the way, I'm listening to an echo, so maybe, yeah, it's probably making you crazy. So if you lower the speaker volume either on your computer or your phone, we're gonna get rid of that. So either or, the speaker volume. And in the meantime, we have another question. Could migraines be hormonal? And I think,
yes.
okay, because you know, a lot of women get migraines around their periods.
So we actually, it's one of the triptans, it's called provatriptan.
Wait, hold on 1 second. I think you did the opposite. I think you probably went with the volume up instead of down, because now I hear the echo more.
How about now?
Better.
Now?
Keep talking. We'll try.
We'll have to work it out. There is a triptan called provatriptan. Usually if it's a patient who only gets a headache around her menstrual cycle, that's a medication I use. But yes, hormone, menstrual cycle, and when menopause is starting are the two hormonal times for a woman where the migraines can start to change how often, how strong.
Mhm. Is there any relationship between migraines, or you might mute one or the other? That's another thing that you can do. Either mute your phone or mute your computer. Oh, perfect. Much better. So I was gonna say, is there any relationship between migraines and depression?
That's tricky. Is the migraine causing depression, or is the depression causing the migraine?
Okay.
So it depends. Because I'll have patients who have both, and you can't really tell which is which started first. because depression can lead to migraines, and any symptom can lead to depression if you have enough of it.
Mhm.
If you have
If you have migraines every day,
I
and I can't go to work, my quality of life is down, you can become depressed. So there is a link. Which direction? It depends on the patient.
Mhm. Okay, but it's not related in the sense that there are like some chemical imbalances in your brain that can cause one or the other, or any side effects of medications from migraine that will give you depression. That's not like that.
What do you mean?
Like, for example, that we could say that some of the since all these medications, I guess, work in your brain, that we could say that that alters something in your brain that will end up in depression or anxiety, that it's some of the side effects of the medications.
That's a good.
I'm a researcher.
Like I said, anything is possible. Probability, I would say low, because you're not taking it in the dose. So let me go back. Most migraine meds, not new ones, are also used, because I get this a lot. Doctor, I see that it's used for seizures and depression. Yes,
Mhm.
these medications work on receptors in the brain, so they can affect headaches, seizures, or depression. Depending on the dose, it can be used for any one of the three. But there's not a link that it will cause the other ones. If there's something off in that area, this is a treatment. The dose will depend on you, the symptoms, and pre-existing. I do have patients who already have depression, and they'll come in with migraines, and we'll say this can be used for both, 2 birds, 1 stone, but we'll do it at this dose. It's high enough for migraines and low enough for depression. It's not going to be overloading. You'll be fine. So once again, and this is why I think you should see, I know patients like to self-diagnose and self-medicate and Dr. Google, but these fine-tuning, you need someone to say, this side effect can actually be a good side effect for you, and this can help you over here. Like, one of our migraine meds can cause weight loss. So for a patient who is trying to lose weight for other reasons and might have other pre-existing conditions, this medication would work. It's going to cover this and this and this, and it's one med. Versus I'm on 4 medications, my primary put me on for this, my primary put me for that. This will cover everything. So there's side effects and benefits and risks that we can look at to cover things, including depression.
Mm-hmm. So I'm a very positive person. I always like to look at the bright side of things. So what I'm getting here is, if you have migraines, you can get Botox and weight loss medication.
Yeah, you sound
Things
like
that
most
you usually don't get covered by insurance.
They're like, this is great.
That's my conclusion today. Okay, so I don't know if we have any more questions from our participants. So hurry up, because we're running out of time. So Dr. Arian, is there anything else that you would like to share with us about migraines that you think we haven't covered today?
It actually has a lot of research. Like, there's even now still new medications that are coming out, different areas. Most of the medications they're working on is to have less side effects. Because the older medications, even though they work great, they have side effects that might cause a patient to stop, or they'll cause other issues. The new meds are good. And now there's also studies that show acupuncture can help. Massages actually can help. Certain over-the-counter medications can help. So it's even though it's one of the top 5 causes of disability, it has a lot of potential.
Mm-hmm. And you just said something, when you mentioned massages, acupuncture, stress. Let's talk about stress a little bit and how stress can trigger migraines.
So stress can cause anything.
Mm-hmm.
Stress can cause any issue, because it's like if you put, if you have a table and you put too many things on it, anything you put is designed to have enough strength to carry something. When you add too much, it has a chance of bending, cracking, or breaking. Stress is no different. Stress can cause physical issues. I mean, heart issues, brain issues, worsening of diabetes. It can cause a lot of things. So yes, there's a stress component to migraines. So, and that is one of the triggers. My patients will say, I'm under a lot of stress. It was a very bad time this week, and I noticed my headaches were up. And after the situation calmed down, they've got, so yes, there's a direct link between stress and migraines and headaches, actually.
And we have a question here. What about heat? Can heat
Yes.
also give you migraines?
So we break it down into food triggers, environmental triggers, and then I'll say emotional triggers and other. So environmental triggers, too hot, too cold, barometer, so the weather changes. Some patients get headaches when it's about to rain, like they know that it's going to change. Some patients, when they fly, the change in the air pressure, I know I'm going to have a migraine for the next 2 or 3 days. So yes, heat exhaustion is one of them.
Okay. Okay, that's all the questions that we have for now, which is great. So you have answered all of our questions, Dr. Arian. Thank you so much. And
No problem.
I don't know if I'm leaving something. I don't think so, but let me just check the Q&A and the chat. I think we're clear. So to all of our attendees, thank you so much for being with us today, but a special thanks to you, Dr. Arian, and thank you for struggling through all the
Sorry about
connection
that.
issues. Thank you so much for hanging there and being with us. I know technology sometimes is not the best, but you made the best out of it. So thank you so
Thank
much.
you.
And if you want any more information about migraines, Dr. Arian, is there a direct phone number to your office? Because I wrote the hospital phone number.
We have,
chat.
hold on, because I'm actually sitting up the desk. 845-353-4344 is the office.
Okay, that's perfect. And this was Dr. Andrew Arian with us today, neurologist here at Montefiore Nyack and a specialist in headaches, migraines, and a whole bunch more of things that you probably want to say because I don't even know how. But thank you very much for being with us today, answering all of our questions. Thank you to our attendees. And again, if you have any more questions, suggestions, topics that you would like to hear here in community chats, don't hesitate. You have my email. Always send us the email, and we will be sending you the link to the recording very soon. I can promise. I used to do it the same day, but I've been busy these days. So if I can do it today, you'll get it today. If not, as soon as I'll do it, you're going to get a recording that you're free to share with anyone that you feel this information can be useful. Dr. Arian, thank you so much. And I hope that we'll talk soon and we'll see you again.
No problem. Thank you so much. Have a good one.
You too. Thank you, everyone.
Bye-bye.